Hello, I'm Norman Swan. Welcome to this programme on improving bowel continence. It's the last in our three-part series on continence. We're coming to you across Australia through the Rural Health Education Foundation's satellite network. And as usual, you'll find a number of useful resources on this programme available on the Rural Health Education Foundation's website, rhef.com.au. About 1 in 20 people, or about 1 million Australians, have poor bowel control. It affects up to 1 in 5 men and about 14% of women. It's a problem that can affect people in all age groups, but is more common in the very young and in the very old, and is one of the major causes of admission to a residential aged care facility. Fecal incontinence can cause severe embarrassment, discomfort and social uncertainty. And it's estimated that 70% of people affected don't actually discuss it with their health professionals, including their GP. Tonight's programme is going to have several case studies which will focus on some of the key points that might be useful for you in your practice. So let me introduce our panel to you. Elizabeth Gasparini is a dietitian from the Royal Women's Hospital in Melbourne. Welcome, Elizabeth.
Thank you, Norman.
Sue Markwell is a physiotherapist from Boonah in Queensland. Welcome, Sue. Jamie Keck is a colorectal surgeon, also from Melbourne. Welcome, Jamie.
Thank you.
Steve Marburg is a continence nurse, and he's the coordinator of the National Continence Helpline, which is part of the Continence Foundation of Australia. Welcome, Steve.
Thanks, Norman.
And Jeff Chapman is a general practitioner from Hobart. Welcome, Jeff.
Norman.
Sue, what are we talking about here? What's the definition?
The definition of fecal continence is the ability to perceive and retain rectal contents until there's a suitable place to evacuate. And the converse, of course,
is the inability, which
inability.
Presumably, as I indicated, has devastating consequences, or can have.
Very much. It can cause social isolation, and just as you mentioned, people don't talk about it, don't in fact tell the doctor, and just hope for the best.
What's the spectrum that you see in general practice, Jeff?
Well, Norman, women, particularly post-childbirth, obviously present more, but there's, I think, an increasing awareness that it's a problem that affects men just as much, if not a bit more. And the particular problem of post-prostate surgery is something that I'm seeing more of.
What, secondary to radiotherapy or secondary surgery?
Yes, often secondary to radiotherapy, yes.
Steve, what sort of symptoms do people complain about when they phone up the line?
They complain about constipation is one area, and therefore some soiling afterwards. They also complain about fecal incontinence, actually evacuating without getting any sensation beforehand. We certainly talk to people, parents of children who are constipated as well, and that can create problems also with bedwetting. But mostly just how to manage problems, how can they get out of the house because their bowel is controlling their lives at the moment.
And whilst I confidently quoted statistics to the audience a moment ago, do we actually know what the prevalence is if people aren't talking about it?
I think the statistics are a bit ropey, but some statistics I do have. In 2002, 21,800 people were admitted to hospital purely for constipation, and around about in 2005, about 440,000 men and 400,000 women were diagnosed with fecal incontinence.
To use an unfortunate phrase, how tightly bound are continence and constipation?
Well, certainly constipation is quite often the precursor to fecal incontinence. But there was just so many things that can happen to create one or the other.
So what are the causes, Jamie?
Look, in my practice, in particular as a surgeon, a lot of the patients I see are women. I know the statistics suggest that as many men as women are affected, and I think that's probably true in general practice, but I mainly see women with incontinence, and in a large number of them there is a history of some form of obstetric trauma, either a direct injury to the pelvic floor at the time of a vaginal delivery or possibly some pudendal nerve damage. But there are also other groups as well, and that includes patients who have had prior surgery, so patients who have had surgery for anal fistulas, occasionally surgery for anal fissures, and also people have had surgery for bowel cancer or ulcerative colitis. So that's probably the main spectrum. There's also a smaller group of patients that have rectal prolapse that present with incontinence.
Where does pruritus ani fit into all this?
Well, pruritus ani, which is perianal itching, is a common symptom, and certainly it's a common reason that patients come and see me. One of the causes of pruritus is fecal incontinence, particularly passive incontinence with mucus loss or stool loss, and that's one of the things that I look for because it's often one of the things that I can treat. But it's fair to say there's plenty of patients that have itching who don't have incontinence.
Elizabeth, are there many myths as a dietitian that you come across in this area?
I don't think there are any myths around incontinence. I think most people are clear about whether they're incontinent or not.
It's fairly obvious.
It's fairly obvious, but there are myths around constipation. It's quite common for people to think that they're constipated simply because they haven't had a bowel action every day. But in actual fact, you don't have to have a bowel action every day. We're simply looking for well-formed stools that are easy to pass. And for some people, that will mean a bowel action daily. For others, it might be once every 2 or 3 days.
So you've just done a randomised controlled trial, which we'll come back to the results of in a moment, but in that you also discovered some of the risk factors in a population-based sample.
We discovered people who had strained at the toilet, who had actually used an outside toilet, and certainly the group of people we were looking at were Queenslanders, and sewerage came late to Queensland. We were looking at people who'd worked and done a lot of heavy lifting in their life, who had back pain. We also had 10% of the study who'd previously been in the army and had done a lot of sit-ups, so moderate to heavy abdominal work, moderate to heavy lifting, straining at the toilet, symptoms whereby they would empty their bowels and go back again and strain, so that was obstructed defecation, so they'd had problems there and couldn't
Due to constipation or what?
Due to constipation, due to poor diet, and due to the lifestyle effects, because we were looking at an older population. We had an average age of 62 years.
So is the outside toot a proxy for something else, a proxy for lifestyle, or is there something about the shed at the back?
It is a proxy for lifestyle, because if you disrupt the muscles that control the way you breathe and your support for your lower back, and if you use your muscles inadvertently, you will actually affect your pelvic floor and you'll destabilise your pelvic floor, causing a drop and poor anal control.
So back injury was a key factor.
Back injury was a big one. In fact, the simple act of falling on your tailbone was very significant. What we looked at when we asked questions was that if we had a rate of over 50%, then we considered that this was highly likely, and we had rates of 70% and in the high 60s for things like fall on a coccyx, where you can actually cause soft tissue damage to the attachments of the purococcygeus, the anococcygeal raphe. And these things aren't noticed and can lead to problems later on. Of course, we had the usual of people who'd had multiple deliveries, and we had a variety of other people who came. But the underlying factor for across the board, no matter what, is what do you do with your muscles? How do you damage them? How can you improve them?
What red flags do you have in mind when you're taking a history, Jeff?
Change in bowel habit is the main one, and that's what we've been taught as medical students. The passage of blood and unusual amounts of mucus, increased or large amounts of wind, and weight loss.
What are the key questions you think are important to ask, apart from those ones, Jamie, in terms of the patterns of incontinence that you can find that might give you clues?
Well, look, I just support Jeff in that it's important to exclude other bowel diseases, but mostly that's been done by the time patients come to me. When I'm taking a history, the things I really want to determine are, firstly, does the patient have mainly active incontinence or mainly passive incontinence? Now, active incontinence is patients that are really subjected to severe urgency and have problems with whole stool accidents if they can't make it to a toilet. That tends to be a pattern that you see in patients with damage to the external sphincter muscle. Patients with passive incontinence who mainly have soiling and dirtying of underwear usually have problems with their internal sphincter, and that will often determine how I'll treat them. So I think trying to differentiate between the two, many patients have a mixed pattern, of course. And the other thing that I always try and determine is just how much those symptoms affect the patient. There are some patients who are quite happy to put up with minor degrees of incontinence and therefore would never contemplate major surgical intervention, whereas there are other younger patients where even any small degree of incontinence is socially terrible for them. So I think you need to get an assessment of the impact also of the symptoms.
Steve?
I was just thinking, when we were talking about symptoms and diagnosing, I mean, one of the things we talk about on the helpline is the Bristol stool chart, and actually just describing what's actually going on. Is things rapid droppings or is things liquid? And gives us an idea of just what the problem is and where to go to help.
Where can you get one of those charts?
Call the helpline.
And ask for the chart.
And ask for a chart. It's certainly a useful tool for the public who just don't really know exactly what is normal, to give some idea about this is what you're looking for. But a lot of people still don't look at their poo.
Let's talk about diagnosis and assessment and management in the framework of case studies. And our first one is about Dawn, who's 58 years old. And over the last 2 or 3 years, she's gradually developed fecal and urinary incontinence. She has symptoms of irritable bowel syndrome with intermittent loose motions. She complains of fecal soiling, and in fact she already wears pads. Rarely she will have a bad accident, and usually that's when the stools are loose. Her obstetric history is 5. She's got 5 children, and they were uncomplicated vaginal deliveries. Your patient, Jeff?
Well, she demonstrates a number of the things we've already talked about. There has been a change in bowel habit. She's got a significant obstetric history, and there is the possibility that she's got irritable bowel syndrome. So I think each one of those deserves attention.
Steve, if she phoned up the line, what would you be asking her?
I'd be asking her just what else is she doing? How is she using her pads at the moment? Are they the right pads to be using? They're not menstrual pads, they're actually pads designed for fecal incontinence. And what help is she seeking at the moment? Who is she told, and where is she going for help?
What would be the differential diagnosis here, Jamie?
Well, this woman is a very, very typical sort of patient that I see, and she's probably got a number of factors going on. She probably does have a true motility problem with her bowel, that is to say she probably does have some irritable bowel syndrome, and that can be difficult to manage. She almost certainly has a degree of pudendal damage. If we were to do pelvic floor studies, for example, anal manometry, we'd find she probably had lower than normal resting tone and lower than normal squeeze function. If we did an ultrasound, we might see some signs of minor sphincter injury from previously. And she'd almost certainly have problems with her pudendal nerve latency, which we can also measure. So she's got a degree of neurogenic incontinence along with her tendency to diarrhea, and it's a difficult group to manage.
What would you exclude in her?
Well, she needs to have a colonoscopy. It's important to exclude a colorectal tumour or a villus adenoma. It's important to exclude...
This is because she's in her late 50s and presenting with
she's got loose stool. So I guess I'm assuming these things have been done, but you'd want to exclude colitis, either ulcerative colitis or Crohn's disease, or indeed microscopic colitis. Some patients get loose stools and have a normal appearing colon, but in fact have microscopic colitis on biopsy, which can be treated. She may have celiac disease. But assuming all of those things have been excluded, she's the sort of patient that I would generally refer to a physiotherapist like Sue for treatment, and also often a patient who would really benefit from seeing someone like Elizabeth, because there may be specific food intolerances or there may be some dietary issues that can be addressed.
So Sue, now's the time to tell us about your randomised controlled trial before we get down to asking about Dawn.
It would be very important to assess her rectal compliance and sensation. And having a baseline of those measurements would be very good, as well as asking the referring surgeon perhaps if she might have had a defecogram, so we could see what is happening with muscles. And in the randomised control study...
But Jamie doesn't believe in defecograms.
I think that may be an option.
And you've brought some defecograms to show us.
Yes, I have. Perhaps we could see the first one. This is an example of a patient who has a beautifully outlined rectum, and you can see the catheter coming down. At rest, her pelvic floor is in a good position, and when asked, she was asked to squeeze, and you can see that the little shadow representing puborectalis has increased. When she was asked to evacuate, she strained down, not very effectively, and we can see that there is quite a drop of her perineum and that her anus hasn't very effectively opened, and she was asked to strain further. And if you compare the drop, as you see on the right hand side of the screen, to the markings on the left, you can see that she's considerably dropped her perineum, and anything from 5 to 12 centimetres is not unusual. So having said that, we know that we have a degree of...
So her bowel's acting like a valve almost.
Yes, in fact she'll be squeezing contents out like squeezing toothpaste out of a toothpaste tube.
This is getting to be too much information, but do carry on.
However, so as far as the study, if we had this patient in a study, we would be looking at, hopefully that she was randomised to the intervention group, we would be giving her a standard high soluble fibre diet that we had identified and used for many years. She would be asked to use bulking agents. She would be taught the importance of understanding how her abdominal, lower back and pelvic floor muscles interact. So we're looking at specific retraining. We're not looking at a mass movement that you give for someone with urinary incontinence. This is completely different.
In this case, mass movement being mass muscle movement.
Mass muscle movement, where you actually draw the contents of...
So you're not pulling your tailbone right up. So what are the exercises you give for fecal incontinence?
Well, we certainly don't give anal squeeze. Now, this is contrary to all other studies, as far as I know, that have been presented. So what we would be looking at is how to teach the person to evacuate effectively, and then we would be finding the pubococcygeus and developing skills where she could actually specifically retrain that through the local pelvic floor exercise that we've determined and through her transversus abdominis. So we're looking at the link between transversus abdominis, the lumbar multifidus, the pubococcygeus and the diaphragm.
But if there's a physiotherapist watching this from Kalgoorlie...
Let me show you. First and foremost, physiotherapists love their pelvis. And so we're looking at a position of the pelvis as such. We know the individual muscles. We then teach that to the patient. We can see that this particular pelvis is pathological, so that the perineum has dropped below the ischial tuberosities. We discuss the variety of muscles and how they work, and then we make it very simple and we colour code the muscles. So if we were looking at defecation retraining, then we would use muscles, and in this case we chose blue, to position the patient effectively and to teach the patient to push the rectus abdominis out. So this is actually a lengthening of rectus abdominis, which releases the puba rectalis and the external anal sphincter. And you can see this with a variety of tests. We've done this with transducers, we've done it with defecograms. And so it's very, very important they take a simple home message on how to toilet. When we're looking at improving support, then we're looking at either the female or the male, and this is very important in other symptoms as well. So if we're looking at post-prostatectomy and other urinary problems, then we would identify the muscles concerned, and the pubococcygeus really is the size of a musk stick. We'll never look at those again without thinking about this.
No.
And they drop down. And so we're looking at the drop. So we want to change that and bring back a perineum that has the capacity to drop considerably back to its limits within its
And so what is the
capability.
movement that gets this pubococcygeus?
Well, it's a movement that you all know, being male, but you don't really know that you're exercising this muscle. When you initiate...
Are we about to have an embarrassing moment here, are we?
Well, perhaps I might say that when you're standing at the urinal, you can either find the muscles and initiate a release of pubococcygeus before you push your abdominal wall out to urinate, and you really can't do that and chat to someone at the same time. Women don't know this action, so in order for women to learn how to do this, we actually have to lengthen the pubococcygeus in order to shorten. As we get older, our small muscles get longer and weaker, and our very large muscles get tighter and stronger. And so this action has to be taught to women, and it becomes all part of the circle of learning how to defecate effectively like a male. Women don't do that. And then learning to find these muscles that would be, in the normal situation, things they would do if they spent their life squatting, as once we did, but once we were given the comfort of toilets, the muscles are disrupted.
So your randomised trial was into basically bulking agents to actually get regularise the motions.
The diet
and then
and the bulking agents.
And then the physiotherapy exercises.
Precisely.
And what were the findings?
Well, the findings were that the intervention group, showing all these specific muscles and how they work and how we taught them, improved symptoms dramatically. So within 6 weeks, the patients who were on this intervention
And this is the
program,
dawn kind of patient?
This is the dawn kind of patient, yes. And so they improved their symptoms. They would have improved the urinary incontinence and any pain syndromes, low back pain as well. And they found it easy to do. It may not seem easy, but when we actually handed the handouts
There's an aha moment when you get that pubococcygeus movement.
That's it, absolutely. Now the other group improved too, because we morally could not let one group suffer. They improved, but they were much slower. If we were looking at diet alone, we would have plateaued, but in fact, as time went on, the muscle improvement was shown to be the case. Both groups did improve, but the intervention group was more effective. And we had a variety of measurements. So we had diaries, bowel diaries, we had rectal sensation measurements before and after. We had the estimation of the DPS, that's the descent of the perineum. We certainly did not refuse anyone who had anal tears. They all came. Everyone came as they were. No. The only exclusion
And they've
criteria,
had constipation for 7.5, 8 years.
they had fecal incontinence, an
Sorry,
average length,
yeah.
7.85 years. and they had sought for a variety of treatments. So they were self-referred. They came because they'd tried other things and nothing had worked.
So Elizabeth, what's the story with... Sorry, Jamie.
Can I just make a comment? 10 years ago when I started in colorectal practice with an interest in pelvic floor disorders, it was very hard to find any physiotherapist with this level of interest and sophistication that Sue's just demonstrated. But there have been a series of courses run through the University of Melbourne and other universities, and there are now many physios, even in rural areas, that have got this same sort of interest. And I think having a local physio with an interest in the pelvic floor makes a huge difference to managing most of these patients.
So Elizabeth, tell us the story about diet here with somebody like Dawn.
With Dawn, there are two issues that I'd look at with Dawn. The first one is the fact that she has irritable bowel syndrome. And I think when we're talking about incontinence, we tend to think about what's happening at the end of the bowel rather than what might be happening further up. So problems like irritable bowel syndrome or lactose intolerance or celiac disease will all cause problems of wind and diarrhoea and constipation, which is a problem when you're dealing with incontinence. So those conditions need to be rectified and they need to be well managed. The other aspect that I'd look at with this woman is the fact that she has problems with incontinence more so when she has loose stools. And that makes sense because it's obviously much more difficult to contain something that's liquid than it is to contain something that's solid. So as Sue said, I'd look at using bulking agents to help bulk up her stools and produce more formed stools, and hopefully that would help.
Right, but that's in addition to the diet, but the diet itself?
In terms of diet more generally, we know that fibre is particularly important. It has the most significant impact on bowel function.
But isn't it soluble fibre rather than
It's both
cellulose?
the quantity and the type of fibre. In terms of type, there are both soluble and insoluble fibres. The soluble fibres dissolve in water. They produce a nice soft gel and they tend to travel through the gut without causing a lot of irritation. They are fermented in the bowel by colonic bacteria and that can produce gas. So in concentrated amounts that could aggravate wind, but as part of a normal diet that's unlikely to happen. Whereas the insoluble fibres, they don't dissolve in water, they absorb water, they puff up, they create bulk, and so they'll cause more bowel actions, which is a problem if you're trying to prevent incontinence. And often the physical characteristics of those foods will irritate the lining of the bowel and they'll contribute to motility and gas and urgency.
Jamie, to what extent does diverticulitis go along with this?
Diverticulitis is an extremely common condition, and because it's so common, it's often associated with many, many other symptoms as well, and I think it's very difficult to determine its role. Patients that develop diverticular disease have probably had years and years of increased internal gut tension. And I think the fact that the diverticula there are really more a reflection of the fact that there's been abnormal motility for a long period of time. So I think that while you will often see diverticular disease in this context, a simplistic approach, for example, removing that particular section of bowel doesn't usually help. So,
or antibiotics?
Or antibiotics, no. And really the only treatment we know for uncomplicated diverticular disease is a high fibre diet, and that's really what Elizabeth's talking about, and I'd certainly support the idea of soluble versus insoluble fibre.
Jeff?
But yeah, I'd like to add that you've got to get patients to experiment and find out what works. One of the messages I've had over the years is that it's a very individual dose, and you've just got to tell them that and say, don't get distressed if you take too much and you have an accident. Just wind back, find out what suits you.
Steve?
And I'm just amazed Dawn is able to see all these people here when she only wears a pad. Certainly a lot of women I get on the helpline just wouldn't be going to even come and see anybody because of the accidents they're likely to have and would be totally embarrassed to come out and see anybody.
So show us the pad technology.
The pad technology, there's a pad called a SaniSoft, it comes in two sizes, and basically it's got impregnated with charcoal, so it actually helps with soiling and the smell that comes with soiling. And that by itself may be enough for some people to make them at least be comfortable coming out of the home.
So that's like for the bad skid mark?
For the bad skid mark, yes. It won't hold certainly a large amount, but if a person needs to go out, and what I talk to people then about is using a pull-up. So a proper pull-up which is designed with some technology in the side so nothing will leak out of the pad, the pull-up, and therefore at least gives them the ability to go and seek help and go and talk to somebody, at least secure the knowledge that they're not going to have to change their pants as well as their underpants.
And does that deal with scent as well? Odour?
Right, so it does to a degree, but this is the better one for this fecal incontinence.
Right. Where does rectal prolapse fit into all this, Jamie?
Rectal prolapse is one of the causes of fecal incontinence that I see as a surgeon. Rectal prolapse is a peculiar disease because it's not particularly associated with any form of obstetric trauma. Patients can develop rectal prolapse in the absence of any vaginal deliveries. And I happen to work in a Catholic hospital and I see a series of nuns with rectal prolapse. So it can affect women who have never had babies. It can also affect men. So about 1 in 5 patients with rectal prolapse are male rather than female.
What's the typical story?
Well, I think there are 2 groups. There are the older group of patients in nursing homes or in residential care where the prolapse just develops over a period of time, and it's usually noticed by the carers rather than the patient. But it causes a lot of soiling and gross incontinence. The prolapse can become ulcerated and bleed, and these patients can even get anemic at times. So that's one group where the prolapse is pretty obvious. There are other groups of patients that get it, however, and really present with incontinence as their first symptom. They may not even be aware that there's prolapse present. What they'll notice is that they start having involuntary passage of flatus and soiling of their underwear. And sometimes those patients, when you examine them under sedation, you can pull the rectum right out. And I've certainly had that experience a few times where the patients have not been aware of the prolapse.
So
it's probably a connective tissue disease. It's probably some sort of degeneration of connective tissue. I've seen it in patients with rapid weight loss, for example. I've seen it in patients with Ehlers-Danlos where there is connective tissue laxity. So it's a peculiar condition.
So does the pudendal nerve get damaged then as an inevitable consequence of that?
Yes, it does. And part of the pathological presentation is that the patient loses anal tone, and certainly if you measure pudendal nerve latency, it gets prolonged. And in theory, at least, if you can correct the prolapse, that damage will be reversed to an extent. But the reason some patients have persistent incontinence even after surgical correction is that there's already that damage in place.
And what do you suggest to, say, the GP in a small rural town without much backup, how to make this diagnosis in somebody where you might suspect it, but it's the second sort of person who becomes incontinent?
Well, I think when there's been no real history of obstetric trauma, firstly, and secondly where patients have obvious gaping. And what I look for when I examine a patient rectally is really just to part the buttocks, look at the anal canal and get the patient to gently push down. Now, mostly the anus will stay closed in that situation, but if the anus just opens up, particularly if there's a sensation of mucosal bulging, then that patient may well have some underlying prolapse.
And an examination under anaesthetic?
Yeah, I usually do it at the same time that I do a colonoscopy, because most of these patients who present with incontinence will need to have that anyhow. So it's an ideal opportunity to do the colonoscopy and exclude organic disease, and then at the same time to examine for occult prolapse. Now, a lot of surgeons use defecating proctograms, which is what you alluded to before, and I think the problem with using proctography to diagnose prolapse is that it really is quite subjective, and there's inter-observer variability, and it's not a very objective test. And I've certainly had patients referred with apparent prolapse who don't actually have it.
So,
could I just butt in here? What we find is that if patients tell you they support their perineum, so they're acting as a pelvic floor to empty, or they may use thumb support in the vagina, or they may lean back on the toilet, there's a lot of questioning that we've been able to elicit over 20 years of research to find out what sorts of things to ask patients in order to get the response that we suspect may be the case. And these are simple. They're
so just remind us, so this is indicative of rectal prolapse?
Rectal prolapse.
So just tell us again the questions that you've...
Perineal support, so they actually use their hand and maybe some toilet paper. They may lean back on the toilet, in which case they're negotiating the rectal folds. They may use thumb support into the vagina to empty a rectocele. They may use suppositories, of course, in order to relieve themselves, but combined with a lot of other questions that we can ask with skid marks and itchiness and soiling and so forth, we can determine that that is the likely case and then get them into the city. I love your optimism about these things being in rural centres. They're not, we can't even get funding to be able to see patients in certainly rural Queensland. So maybe we're just a larger
Maybe you should
state.
be heading for Victoria.
Indeed.
Just before we go on, Elizabeth, is there a prescription for good bowel health?
I think the messages about bowel health really are quite similar to our messages about general health, in that a good healthy diet with a variety of foods, lots of high fibre foods in particular for bowel health, regular exercise.
Is there any evidence that exercise helps? Nice to say, but is there actually any evidence?
I think the issue with exercise is more indirect. There's growing evidence that overweight and obesity are contributing factors to fecal incontinence, and healthy diet and exercise obviously are very important in managing weight.
Basotti showed that when you sleep, your colon transit slows, and daytime naps will also slow colon transit. So getting elderly people up and about moving is important. They don't necessarily have a slower transit if they are moving, but they often have rectal sensation changes, so they can have a very insensitive rectum.
I mean, good bowel habits, drinking enough fluid, sitting on the toilet correctly, not straining, all these sorts of general things.
And I think it's important to integrate. Often these people may be obese and they have other health issues. They may have high cholesterol and so forth. And I think it's important to integrate it into that better health message. And we're not confusing them. It is really the same message. It's saying, eat a healthy diet, drink enough fluids, get your exercise. So whilst it may not be the key factor, I like to think that you integrate it into a consistent message, and you're not sending them out the door with one message for their bowels and another message for the other aspects of their health.
Exactly.
Education, talking about this, getting people to talk about their problems is a significant challenge wherever you are in Australia. It's particularly a challenge in Aboriginal and Torres Strait Islander communities. We went out and filmed Esther Quintal, who's an Aboriginal health worker in Western Australia. She's actually done a comic book, as you're about to see, in this area. And here she is in an education session with people in Narama in Maria.
As you know, my name is Esther Quintal. I'm an Aboriginal health worker from Port Hedland, and this is where continence all started for me, along with dementia, because most of my clients had dementia and were incontinent. Step sideways, please. Come in the front so the girls and boys can see you. So, our pelvic floor muscles are down here. Turn around a bit so they can see. Are down there, okay? Underneath there. Most of the time people are very interested because they haven't heard about incontinence or what's causing the incontinence. Yeah. Incontinence is a taboo word. It's a shame job. People do not know help is available. Health professionals are reluctant to bring it up. Can any of you talk to a client and ask them about their incontinence? It's the health worker who should approach the client to come and talk to them, because it's the people who work in HAC, Home and Community Services, that know which client might have developing this problem, and if they catch it early, well, it can be prevented, it can be treated, it could be cured. I don't know if you've already seen the Continence comic that I made. So that's been in circulation for a while. So that's always very good to have as one of your resources. When I did the comic, it was a way of getting the continence message out to the Aboriginal people, because with Aboriginal people, they just go on with their daily lives, and there's so many other difficulties in their lives that it just goes undetected. They've got grandchildren to look after, they've got their own children to look after. They just keep washing them sheets, washing their clothes, till someone comes along and just talks to them. They just become housebound, they don't go out and enjoy themselves no more. And so we thought that the comic would be easy. They could just pick it up, go into their room, have a read, or a health worker might take the comic and read it in a group. You get a lot of laughs from it. Sitting down having a cuppa, you don't have to ask the client straight away, oh, are you wetting yourself? Are you incontinent? No. You've got to sit down and have a cup of tea, talk about different things that they might be interested in, and then you come out and ask them, Auntie Dora, I see you doing a lot of washing. Why are you washing too much? And she might say, well, Uncle Jack, he's messing the bed all the time. I have to wash every day. They don't know that services are available to them, like home and community care, that they could come in and organise some washing to get done for them, give her a rest, take her away to a community centre where she might sit there and have a cup of tea and enjoy herself for the day. Health workers Talk to your client, show the client some brochures, or leave a brochure at home on the table, pretend you forgot it. The client will pick it up. Tell them about the National Continence hotline. There's help available if you're stuck. Your local doctor, your local nurse, community nurse. Be strong and talk about it.
Esther Quintal from Port Hedland in Western Australia. You work in Aboriginal Medical Service, you do consultation. Would you endorse those comments as generalisable?
Yes, absolutely, Norman. I'm not an expert on Indigenous health, but I have been lucky enough to attend the Aboriginal Health Service in Fitzroy in Melbourne for the last dozen years or so. And it's that sort of initiative through usually Indigenous health workers that really has the most impact, I'm sure.
They elicit the story.
Absolutely, and there are lots of cultural issues and even just understanding how families are structured and taboos. I think that's exactly the sort of thing that should be promoted.
Jeff?
Yeah, I think so. I think I'd really endorse those comments.
Let's go on to another case study. Rachel's a 24-year-old woman. She's pregnant. She comes to see you, Jeff, because she actually wants to talk about her next delivery. And she got a relationship with you and wants to talk this through. She had, as you know, a pretty tumultuous time with her previous child, born vaginally, and she had a third-degree tear, which was repaired at the time. She's got no problems with fecal incontinence at the present time, but she wants to go for the safest option. What are you going to advise her?
Well, I mean, look, I'd actually be giving Jamie a call on that and finding out what the latest evidence is before I gave her that advice. I think that's a very prudent thing to do. But I would take the opportunity to talk to her about prevention, because I think this is the time to step in, irrespective of whether she has a caesarean or a natural birth this time. She is at risk, and I think it's a really good time to talk about getting appropriate advice from a physio rather than wait the years until the problem arises.
Sue?
Yes, I think it's very important that our patient would understand the pitfalls of how she could actually cause further lower motor nerve damage, the pudendal nerve, if she continued doing certain things that she habitually did, such as toileting the wrong way, doing the wrong exercises.
What do you mean toileting the wrong way?
Just sitting slumped on the toilet and pushing down into the toilet, which is what most women do. They rush in, hover, or sit on the edge, contract their rectus abdominis and push down, and then they're off doing what they have to do. What they're supposed to do is sit back like a man. They're allowed, well, they should allow their abdomen to flop between their legs. Now, so far we're touching cultural changes here, so we actually have to change behaviour. Allow their abdomen to flop and push their abdominal wall out. Now, that will immediately release pubo rectalis and external anal sphincter and will allow the supporting muscles of the transverse abdominis and the pubococcygeus, that is the supporting muscles of the pelvic floor, to work. So she would need, as she would need to teach her children how to go to the toilet effectively, how not to do damaging sports, so that she wouldn't go to a high-impact gym. She wouldn't go and do 50 sit-ups and change the balance of her muscles. She would perhaps do complementary things like walking in water, doing freestyle swimming, along with walking for normal fitness. She may even learn how to identify her muscles, which we would hope this would be available to her, and to maintain good exercise principles for life.
Do you often get this sort of question on the helpline?
Yeah, I'm just wondering how tall Rachel is, because if she's 4'8", I'd be suggesting a phone book under the feet when she's sitting on the toilet as well. Yes. If she's 6 foot, she probably doesn't need one. But certain positioning as well, sitting correctly on the toilet too.
So, bottom line here, so to speak, Jamie, what does she need in terms of her delivery? What would you be recommending?
Look, I think this case raises some interesting points, and one of them is that the third degree and fourth degree tears still do occur, even with the best obstetric practice, and I think they occur in probably 1% of vaginal deliveries. So I think when women are being talked to about vaginal deliveries in general, they need to know that that is one of the risks. I'm not an advocate for caesarean section over vaginal delivery by any means, but I think it is one of the factors that women need to take into account when they're talking about how they're going to have their baby, whether it's the first one or the second one. The other point, though, is that if a tear is recognised and repaired properly, which is often the case, then in fact the results can be very, very good indeed, as they are apparently in Rachel. What I would do with her is firstly assess her pelvic floor myself. She may have no symptoms but still have a very weak muscle. I would probably, for her peace of mind and my own, refer her for pelvic floor studies. So I would do an ultrasound to see if there was a persistent gap in the muscle, and I'd do some manometry to see that her pressures were adequate. And if her ultrasound looked good and her pressures were good, then the evidence would suggest that her risk of a further injury is no greater than if she was having a first delivery. Now, having said that, there's still a fair chance that after an informed discussion, Rachel would opt for a caesarean section along with her obstetrician, given that she's already had damage. What we don't know is what she'll be like in 20 years' time.
Just going back now, just leaving the Rachel story behind, something I meant to ask you earlier about soluble and insoluble fibres. Just give us a sense of the foods where you get each from.
Okay, the soluble fibres aren't necessarily visible fibres, so they're present more in the smoother wholemeal breads and cereals and in the fleshier parts of fruits and vegetables. Whereas the insoluble fibres are much coarser and they tend to be present in grainier foods or grainier breads and cereals, nuts and seeds, and in the skins of fruits and vegetables. But there's always a mix of fibres in all foods. It's just, that there's usually a predominance of one type over another in most foods.
And what about putting them through a liquidizer, and what does that do to things?
Well, it usually removes skins and pulps it all up, but it'll still be there. It's still just done the job of what
so
your gut would have done.
So you haven't stuffed it up by liquidizing. Maybe a few calorie issues, but apart from that, it's all right. Let's go to our next case study, who's a 52-year-old woman with secondary progressive multiple sclerosis, diagnosed 15 years ago. She can walk on a walking frame, but mostly uses a wheelchair. She lives at home with her partner and teenage children. She had a suprapubic catheter inserted about 6 months ago. She does well with that. She drinks about 1 litre to 1.5 litres a day. She has had piles in the past, and her bowels open every 3 or 4 days, but it's painful and she's having to strain. And Jeff, you've got the highest prevalence of multiple sclerosis in the country, so she's your patient.
Yeah, and I think it also, just in general with these neurological disorders, but particularly say something like multiple sclerosis, ask the question, because you're often focusing on other aspects of the condition, and the constipation is just brushed away, or it's not covered. And I think it's really important to ask the question. In this particular study, though, she clearly needs something to help her manage her bowels and get a much more comfortable bowel.
So what would you do?
Well, I'd go for softeners and try and get her to titrate the dose so that she gets a comfortable and regular motion.
Steve?
A couple of other things. I would try and encourage her to drink a bit more. I would check her diet as well, and if she's never seen a dietitian, I'd probably encourage her to consider that. And I suppose what I talk about is a stepped approach with bowel management. Softeners as a starting, actually diet as a starting point, and then softeners, and then work my way up. You always aim for what's going to be the least nasty but best effective, so you don't hit them with the big guns straight away, because you may need those further down the track with MS.
Elizabeth, her diet?
I think from a dietitian's point of view, a neurological disorder introduces a whole different problem, and I would be reluctant to give this person much advice without referring back to the doctor or whoever who had referred the person, and got some information about the physiological issues and what the doctor wanted, and then I would modify the diet around that.
Sue?
I'd be looking at whether she could transfer easily to a toilet with a suitable height, making sure that physically she could position herself effectively, obviously teaching her how to evacuate, and just making sure that her transfers and her reduced mobility could be enhanced, as well as individualising her pelvic floor management.
Jamie?
Look, just taking another tack on this, patients with spinal cord injuries and paraplegia generally don't have major bowel problems, or at least they can be managed with. There's usually reflex defecation, but the problem with a patient with multiple sclerosis is that the lesion is not complete. She's got partial damage to her spinal cord and also presumably her brain as well, and so these patients present with really a variety of neurological presentations, and therefore it's very difficult to generalise about what you should or shouldn't do in these patients. And unfortunately for this woman, her disease is progressive, and ultimately one of her issues is going to be transferring and getting on a toilet altogether. I haven't often given patients with multiple sclerosis stomas, but I have a couple of times with really a lot of benefit in terms of managing the patient, both for herself and for the family as well. So I think the end stage
where a colostomy would work.
Yeah, colostomy, and you can usually make a sigmoid colostomy laparoscopically, so it's fairly low impact surgery. She's already got a suprapubic catheter, and it may be that at some stage that would be an option for her, although I certainly would regard it as a last option and do all the other things we've talked about.
And our final case study is about Pamela Todd. 3 or 4 years ago, she was diagnosed with rectal cancer. She underwent surgery and she experienced changed bowel function and constipation. Here's her experience.
It was 6 months after surgery and had run into some problems with the bowel function after the reversal. That's when the problems began. Spent a lot of time in the toilet doing nothing or doing tadpoles. I used to tell my, I've been there for an hour and I've only done a tadpole. You know, it was ridiculous. And I was beginning to pay attention to what I needed to do. I had always walked a lot, but I realised that I needed to do sort of hilly walks, you know, a bit more stressful than just walking. So I began to do hill walks every morning, and I'd begun to change my diet. It's your whole digestive system. It's what you eat and your exercise that you need to address. It would make a huge difference to people struggling with, you know, to improve their bowel function. I feel wonderful. I feel absolutely wonderful. By the time I was well, I was asking the Cancer Council, where are the colorectal or the bowel cancer support groups, and found out there weren't any. I was absolutely shocked because it's such a prevalent cancer and, you know, it affects men and women. So I kept saying to them, someone should start one then. And eventually they said, well, yes, but you're the only one talking about it. So with another fellow colorectal cancer survivor, the two of us did.
Like I was thinking, I don't get the same message to go to the toilet like I used to.
Yeah, and that was really interesting.
That's how I feel. You know how you know you've got to go to the toilet, so you go. Now I don't feel the same urgency to go or the same bowel feeling.
My husband's very shy and embarrassed because it is the bowel. And being a so-called macho man, you know, he couldn't be seen to be wearing the nappies.
We're now getting referrals from some of the major hospitals. Okay. We're on the Cancer Council helpline database, so if anyone calls the helpline and they ask about support groups, they can find out. So we've had some referrals from there.
Because of the problem now of having to visit the toilet regularly, we have to be very careful about what he eats, because even like fruit juice and all sorts of little things can upset his tummy. We were very relieved to find that there is an actual brochure or an internet site telling us about the public toilets, because you really need to know where the toilets are.
When new people come, they are always invited to share their story if they want to. They don't have to, but we've never had anyone knock that back, because it's almost a relief to be able to not have to choose your words and to just say how it is. And you know, bowels aren't nice and they're embarrassing to talk about, and so I think it's the first time that people often feel that it's acceptable to share all that stuff, because it's not stuff you share at a social gathering.
Pamela Todd, typical story?
Yes, very, very typical story. As colorectal surgery has evolved, we produce fewer and fewer permanent stomas in patients with rectal cancer, but that means we do lower and lower anastomoses. And so there are patients who survive their bowel cancer with a very low anastomosis in the pelvis, where their native rectum's been removed, and they do end up with a lot of symptoms, both constipation and incontinence. And again, no one-size-fits-all. You tailor a solution to each person. I think that's right. I mean, one of the messages, of course, is that most patients experience improvement spontaneously over time. So most patients need to be patient and need to be encouraged during that difficult early period, so that there's improvement over the first 6 to 12, even sometimes 24 months in my experience. So patients who start off with poor function often improve. Diet's very, very important in these patients. And so, meaning in the first instance, taking a fibre supplement, usually in the form of something like psyllium, is very, very useful, just to bulk up the stools. Patients are afraid of taking fibre because they're already going to the toilet so many times. But by taking a fibre supplement, they're often able to have much better evacuation in the first instance, and they don't go quite so often. Occasionally, patients need to have constipating drugs like Imodium or Lomotil as well. And they do need a fair bit of support, and I think the conversation this woman has had amongst the support group would be very beneficial, and I have conversations like that with patients. I think bowel cancer is still not, even though it's such a common cancer, it's still not something that the public thinks about a lot, and whereas there have been support groups for breast cancer survivors, for example, for a long time, there haven't been a lot of support groups for bowel cancer survivors, and there's a lot of them out there. Steve?
Yeah, I actually remember talking to Pamela and telling her about this excellent resource. a really good overview of managing things after bowel cancer surgery. It talks about pelvic floor, it talks about fluid, it talks about diet, it talks about what else you can do, it talks about how to manage things day to day.
Is that from the Continence Foundation?
From the Continence helpline, yeah, from the government. It's a really good overview, and I remember Pamela ringing me back and saying, I just wish I'd had this years ago when this first happened. And I get that call quite a lot, actually.
And you've had a look at it, Jamie. What do you think?
Yeah, I think it's excellent. I didn't know it existed, so I'm very pleased to have found it, because I think it would help a lot to have that in the office.
So what do you take home messages for the audience? Jeff?
My question, for my colleagues, is ask the question. Just, raise the topic, because people often won't do it themselves. And the number 2 is get the number of the helpline.
Which is my helpline. So my take-home message is really, if you have any questions about bowel management or bladder management, want to know about resources, where to get help, call the Continence helpline, 1800 3300 66.
Jamie?
Well, my perspective is a little bit different. Most patients with fecal incontinence can be managed very, very well without surgery, and there are, as I've said before, there are physiotherapists who are interested and dietitians, and I think it's very important that patients do present and be assessed, because there's a lot that can be done. There are also just a couple of new high-tech operations that are available for patients with severe incontinence, one of them being sacral nerve stimulation, which has now started to become reasonably freely available in Australia, and also other things such as injecting silicone polymers into sphincters to try and stiffen them up. So there are some interventions that are available as well in those patients that don't do well with conservative treatment.
Sue?
Education, learning how to toilet effectively, preventing the problems in the next generation, bringing it in at schools, and helping people who already have the problem by learning how to use their muscles effectively.
Elizabeth?
Firstly, I'd emphasise the importance of prevention, so looking after yourself, prevent constipation, prevent weight gain, exercise regularly. And secondly, for those people who are experiencing symptoms, diet's a very simple, effective and economic way of managing symptoms, which can be used as an adjunct to their medical management.
Thank you very much to you all. And I hope you've enjoyed and got a lot from tonight's programme on improving bowel continence. If you're interested in obtaining more information about the issues raised, there are a number of key resources for you. The Australian Government's Department of Health and Ageing's Bladder and Bowel website, bladderbowel.gov.au. The Continence Foundation of Australia's National Continence Helpline is, as you just heard, 1800 3300 66. And the National Public Toilet Map website, which you heard somebody referring to in Pamela's support group, and that's at toiletmap.gov.au. There are more resources available on the Rural Health Education Foundation's website, rhef.com.au. Now, don't forget to complete and send in your evaluation forms so that we can keep on improving our service to you. And please register for CPD points by completing the attendance sheet. Our thanks to the Department of Health and Ageing for making the programme possible, but thanks also to you for taking the time to attend and contribute. I'm Norman Swan from all of us. See you later.